Hello, and welcome to this Georgia Dental Association webinar of 2020 concerning novel tray options for bleaching, sensitivity, caries control, and splints in a pandemic. My name is Van Haywood. I'm a professor at Augusta University Dental College of Georgia in Augusta, Georgia. And I'd like to welcome you to Augusta, which is right on the border of Georgia and South Carolina. Most of you are familiar with that because you've either been to school here or grown up here. We're also known for the Masters Golf Tournament. And of course, this is the year that there's not going to be any patrons. So it's going to be an unusual time for Augusta in a lot of different ways. This is our new Dental College of Georgia, and I hope you get a chance to visit it if you haven't already seen it. It's a massive structure with over 300 clinical operatories, and we're proud of all the things we've got there. We have a new department chair for our department, Dr. Kent Knornshill, who used to be here on faculty. Some of you may have gone to school when he was here, and he's come back from Chicago and brings a lot with prosthodontics and CAD-CAM and a lot of the digital dentistry as well as implants. So looking forward to seeing his reign here as other folks have begun to retire. We're trying to get used to going from what we were with just masks when we were covering clinic to now we got the full PPE, much like you have, and just a little bit more of a challenge with these big open bay clinics. But we're trying to make all that work. Now, what my goals are today are to help you make sure you understand the difference between bleaching and whitening and just kind of generally review the bleaching principles, especially the difference between carbamide and hydrogen peroxide. And then discover, because of those, discuss some of the different types of novel bleaching tray fabrication techniques other than the conventional, which mainly includes thermoplastic trays and some impression techniques, as well as discuss some of the different methods for splint fabrication made directly in the mouth or using any articulator. I've been doing this for over 30 years, and so I've been supported by a lot of different companies, but none of them have any influence on the content of this particular lecture. Currently at the dental school in my faculty practice, I use 10% carbamide peroxide with a thickener. That was what our original article in 1989 was, and they used to be ADA approved, but now ADA does not approve any things that are sold directly to dentists. They only do over-the-counter products. But I prefer using that, and because I'm using that low concentration of material, I can use a non-scallop, no reservoir, horseshoe-shaped soft tray. If you increase your concentration or have some super sensitive patients, you may have to scallop the tray. But with 10% carbamide peroxide, it's actually made to go onto the tissue. And so the gingival indices all improve during bleaching because the gingival health gets better. And then carbamide peroxide is active for a long period of time, so it works best overnight. Some of our early research found that patients complied better if they did it during the night rather than the day. But if you're going to use carbamide peroxide during the day, it's going to be 2 to 4 hours. And then you can tell people that normally normal teeth will probably take 2 to 6 weeks, but some of the longer things like nicotine stains and tetracycline stains would take 2 to 6 months, maybe even longer. Now, understanding the difference between the materials, we're not going to spend much time on this, but you've got two basic materials, carbamide peroxide and hydrogen peroxide. And carbamide peroxide is made up of hydrogen peroxide and urea, but the concentrations are important. 10% carbamide peroxide is equivalent to 3.5% hydrogen peroxide. So make sure you know what material you're using and what's the concentration, because these techniques I'm talking about today work with the 10% carbamide peroxide. They're very different in how they act. Hydrogen peroxide releases half of its material in 30 minutes to an hour, and so it's only good for about an hour's worth of wear. So it works best during the daytime. Carbamide peroxide releases half of its material in about 2 hours, and then you have a slow decline over the next 6 to 10 hours. So it's best worn overnight because you get your best bang for the buck. And the reason I like carbamide peroxide is because the tooth can only change color at a certain rate, and that rate most closely matches with the carbamide peroxide release of overnight wear. So after doing this for over 30 years, I found that you got to evaluate the cost, the safety, and the efficacy of your products. And with those, I find 10% carbamide peroxide in a soft tray is the most cost-effective, safe, efficacious way to bleach teeth. You can use higher concentrations, but you're going to get more sensitivity and a greater rebound when the shade drop happens. You can use boil and form trays. They're not as nice as the custom soft tray, but that's one of the areas I want to share with you today. In-office is on a completely different mountain. It's going to take about 3 visits to give you the maximum whitening, and a lot of that has to do with dehydration from the isolation technique. Crest white strips work, but it takes about twice as long as what they claim in order to get lighter teeth. And then some of the over-the-counter products, especially toothpaste and chewing gum, don't make any difference in the color. So my preference is 10% carbamide peroxide in some kind of soft tray, and that's what we're going to talk about today. Now, we're going to just discuss some of the different options other than the traditional bleaching tray that we just talked about. Now, we're going to include direct thermoplastic trays that were double white, single clear thin, single clear thick, and then we're going to talk a little bit about some different ways to make impressions if you're going to make a conventional tray like a closed mouth, alginate, a putty wash. And then, if time permits, we're going to discuss just a little bit about splint options that you can preserve the vertical dimension of occlusion or create the splint directly in the mouth. Now let's start off with bleaching, and the first thing to recognize is that bleaching is not the same as whitening. Patients may ask, why should I come to the dental office and get my teeth whitened when I can buy whitening toothpaste? And actually, bleaching changes the inherent color of the tooth, whereas whitening has been used by manufacturers to only discuss removing surface stains. So if your patient is using a whitening toothpaste, they're basically just taking the stains off their teeth, but they're not changing the inherent color of the teeth. Now, of these novel tray options, the first one I want to look at is my favorite, the thermoplastic dual white one. And this is one where you avoid the impression for the bleaching tray. It's made directly in the mouth. And of course, this is very good for gaggers and gives you shorter appointments, and it gives the best dentist control of all the thermoplastic trays that we have. All these work best on the maxillary arch, and of course, if you can cut down on time and expensive materials, you can cut down on fees and have a better option for your patients. Any kind of thermoplastic tray is made directly in the mouth, and we're going to use hot water to soften, but that avoids the gagging that a patient may have from impression, and it gives them a chance to immediately start bleaching, which saves an appointment time or a separate appointment that we're going to do. So when I say dual blue-white, this is the tray system we're talking about. It has a white inner core and a blue outer core. After this, we're going to go through the single clear thin and a single clear thick. But let's start with the blue-white. And the idea is the inside is rigid, and it's got a soft thermoplastic outside. And this one, the dentist has the best control over getting a good fit. It also works quite well with bruxers. If somebody's not sure they're bruxing or not, I'll show you how we're going to use this to evaluate that. And it also could be used with caries control in patients who have limited ability to help to be able to apply the carbamide peroxide, which reduces root caries. And then when we have it with bruxers, we can use it diagnostically to see if they're currently bruxing or even see if they can wear splints. We'll kind of touch a little bit on those different things. So the blue-white system is basically two separate trays, and the hard inner core is what you're going to use, and the outer one is just used to carry it to the mouth because it gets so soft when it gets hard. So you'll see a two-tray system. After we made it in the mouth the way I'm going to show you, you're going to have a custom-fitted tray. You peel away the outside, and you're left with the inner inside that's custom-made, and that's what the patient wears for bleaching. So let's take a look at this. We're going to use that boil and form technique, and again, this particular style tray is useful in patients who don't have good lip control or they can't cooperate well, and it's especially good for children, pediatric patients, or handicapped special needs kind of patients. And we have a number of articles on my website I'll show you at the end where you can read some about these areas. Generally, if you're using a microwave, you got to heat the water for about a minute and a half and then submerge it and soften it up, and then you're going to use your hands to form it. When I first started using these, I would use a ceramic cup in a microwave, but you had to sterilize the cup for each patient. It takes about 3 minutes to heat it up, and you need to have a real wide cup. Now I've gone to a Keurig coffee maker. It makes it about the perfect temperature for these thermoplastic trays, and all you got to do is have the cup ready to go. You could use a styrofoam cup or whatever, which you can't put in a microwave, or you could use a hot shot. But my preference is this one. Just make sure you've got the Keurig pod out of there because you don't need coffee or tea in there. And then use the largest amount of water you can and the largest wide mouth cup you can to put things in there. So you're going to wind up just closing it with nothing in there, and then select the largest size you can, and of course make sure your cup's big enough to carry all that water, and then you want to fill that cup up with your Keurig coffee. Once you've got it filled and it's hot, you take the tray and wave it around, and the coolest part of the water is on the surface. So you're going to watch that top edge and see when it starts to roll back. Then you know the whole tray is uniformly softened in the water. You shake the water off when that starts to curl back, and bring it out, and then you're going to unfold it where it started to fold over. Because if it sticks to itself, it won't come unstick. So you have to open it up like you see there in order to be able to get it into the patient's mouth.
Just relax your lips like you did with that X-ray. Open just a little bit.
So you're forming it very hard, pressing with your fingers as tight as you can, squeezing on the inside and on the outside.
Okay. Now close on your back teeth. Put your lips, close all the way down on your back teeth. Put your lips right out and kiss your boyfriend. Do suck a pacifier. Keep your teeth together though, just like like you're kissing really hard.
So you're trying to let the patient create the vacuum suction.
And we're just going to do this several times. I'm going to do my little thing, and then you do your little thing.
But you notice how you have to press really hard and really fast.
Put your lips right up. Kiss your boyfriend.
And just keep that pressure, making sure they close on their back teeth.
Middle schoolers, I have to come up with something. They don't kiss, so I have to come up with something fun. All right, got it? Let's do it again.
So again, each time I'm pressing it out. You'll notice I'm going to just move it down just a little bit, because if it's locked on there, I want to stretch it up and down a few times to loosen it up. In this case, it's not tight at all, so I'm going to keep pressing as hard as I can.
Okay, closing the back teeth.
And then have her.
Is it still warm? Mm-hmm. Okay, keep real tight suction. You're actually acting like a vacuum former and sucking that stuff around your teeth.
So I'm letting it cool down, but I want to keep it in the mouth and keep the suction and the finger going while it's getting cool. You notice I tried it again to make sure it wasn't too tight. So I'm pressing really hard and squeezing on the inside.
Something work? Any heat left in there? A little bit? Yeah, okay. It chills down. And what we're going to do is finish chilling it under the sink with water. Tight suction. Just all right, let's go.
So once it's lost all its heat,
can you heat it all up? Let's see. All right, I'm gonna take it out. See how it's coming. All right.
Then I've got a custom fitted tray made directly in the mouth, and you see how one edge of it just folded over on that back corner. But now I'm going to take that over to the water, and I'm going to chill it. And again, I'm washing the saliva off, and also squeeze just a little bit more while it's under that water. And then it's kind of like selling butterbeans. Now you got to find the edge of the tray and kind of peel it out all the way around. And again, now that white inner is pretty rigid from the water running all over it. And so I can get that out and wash it off, and then I'm ready to take it back to the mouth and see how things are going to fit.
Back in.
Then you just got to find where the midline is, slide it in place, and then you'll have them close on the back teeth and look and see.
Close all the way down.
See if there's any involvement with frenums or any
rough there. I might do a little rubbing. Can you close all the way together? Does that feel good? Mm-hmm. All right, smile a little bit. There you go. All right, turn it off.
Okay, and then once I found that little rough edge that I didn't like, I'm going to take it back to that same water. I don't have to reheat it. It's still plenty hot. And just kind of soften that one little edge so it's just a little bit floppy. And then I can put it right back in the mouth and just use my finger to squeeze
the edges just a little bit like that. Okay, back down in the back teeth. Now, wiggle your lips from side to side with them closed. Anything feel sharp? Mm-mm. Okay, all right, that's good.
Now we have a custom fitted tray made directly in the mouth.
That's good.
And that was a real-time video. They don't look very neat. They're just big white glob of things, but it works really great on children. And with them, since they still got primary teeth, I can provide the service probably about half the fee of what my regular bleaching is going to be. And so you can use that clear tray or this white one, but the white one gives you the better control. And it works best on the maxillary arch because of the way their tongue provides the suction. Very difficult to make it on the mandibular arch. The other thing that's nice about it is that if you don't want to re-soften the edge, you can just trim it smooth with the crown and bridge scissors. And then if there's some little edge or something on it, you can just kind of get one edge in it. Or if they didn't bite correctly in the occlusion, you can just kind of hold it over the surface of the water and just let it get softened up the occlusal edge and then put it back in. They can bite in place. So you can reform the edge or the occlusion in the mouth selectively rather than reheating the whole tray and actually create a very nice fitting tray. Again, very difficult on the mandibular arch because they can't use their tongue very well. And it's just much better to do this on the maxillary arch. So usually what I tell patients is, why don't we try this technique once I feel like they're a good candidate, and if it works on the top arch, it'll only be about half of the original fee, but if we have to do the bottom arch, we'll have to do the conventional tray impression technique. It's also if I have somebody who's a bruxer and I'm worried about them grinding a lot on that tray, I'm actually going to use this kind of tray to put in the mouth. And if somebody says, well, I don't think I'm grinding my teeth now, and I'm seeing all these wear facets, this is a good diagnostic tool to see if they're still bruxing. And if they also admit they're bruxing but say, I don't think I can wear a tray at night, this is a good way for them to try a tray without going through all the expense that you need to do it. So here's somebody who is a bruxer, and again, you can see in a couple of weeks or so, they'll grind the holes in the tray. So it makes a good diagnostic apparatus to figure out whether somebody's bruxing or not, and just determine, do they have the ability to wear splint. But it also works great for bleaching. And all these trays come from a company that started the original football mouthguards, archtechinc.com. They moved from the Midwest where they started out until to the East Coast. But this is about 6 trays for $12. So it's about $2 a tray when you're going to use these. But again, there's no other additional cost in doing that. Now the companion tray that came out after this one is just that clear thermoplastic tray. Same idea, going to use the water again, submerge the tray and wave it back and forth just like we did, but we just got one tray this time. So we can use our Keurig and we can use a hot shot, or you can use a ceramic cup, whichever way you want to do. While my assistant's getting the tray ready, I go ahead and try it in the patient's mouth to make sure they understand how it's going to go in and how they have to close on their back teeth, because that's most common thing, as you know, as a dentist, they tend to want to bite on their front teeth. So have them close on their back teeth, and we practice it. I explain to them that it's going to be warm, but it's not going to be hot. So what I got to do is I'm going to wave it around and watch that leading edge, leading edge again, and see when it starts to fold down. And then you got to really hustle. Now this is kind of slow here, just so you can get it on the camera, but you got to really hustle to flip that back and then take it to the mouth. And don't let it touch itself anywhere. You shake all the water off because the water was hot, but the tray is just warm. Put it in the right place, and then they immediately bite down and put the suction on it. So this works well when you have a patient that has good embouchure control and loose lips, so you can get it in there very easily. I check it once just to make sure they did it in the right place, because if it went off center, I can't fix it. I just have to throw it away and do another tray in there. But usually once you get the hang of these, you can kind of center them up with that little area. And just like the other one, it could be trimmed with crown of bridge scissors, and we can resoften the edges like we did with the other one and just kind of reform it in the mouth. And again, these also come from that same company they call ultra thin dental trays, and it's about $10 for 12 trays, so about 82 cents a tray. So very cost effective and works quite well on people with loose lips and stuff. These trays are pretty tough, so patients don't easily grind through them. And you notice on that right screen, they have a thick lingual wall. That's because when it gets soft, that facial wall is not rigid enough to carry it to the mouth. So you have to have a thicker lingual to be able to hold that. So this is a 1 millimeter thickness of a tray. And as you can see, that facial is really thin, so you can trim it with crown of bridge scissors, just like you would any other kind of tray. But the lingual is very thick, because that's what gave it its rigidity. So you can't do any fancy trimming. You can't scallop these trays well. You can't keep them off the palate. That's why it's so important that you're using a 10% carbon biperoxide, because again, that's a material that you can buy over the counter called glyoxide that's made to go on wound healing. So it's an oral antiseptic. So there you have a custom fitted tray made directly in the mouth. We're going to go back, because where we cut it with the scissors, it tends to get it a little bit sharp on the edges, and put it back in and let the patient wiggle their lips from side to side and form that vacuum again, and that just softens it up real good. So now we have a custom fitted tray made directly in the mouth, and that was a real-time video, so it gives you an idea as to how quickly that comes around. When these first things came out, and we were approached about them at the dental school, I didn't think they were going to work. So I wrote a grant for doing the study, thinking that I would probably have to make half of them over, and out of 30 patients, I was able to make all 30 bleaching trays for the maxillary arch in 1 or 2 tries. But again, you have to accept that you're not going to be able to scallop it, and you're not going to be able to put reservoirs. And of course, we've shown with 10% carbon biperoxide, you don't need reservoirs and you don't need scalloping, because it's made to go into the tissue. Plus, you get a better seal against the tissue. Then you can use your crown and bridge scissors and you can cut the edges and cut the handle off. As you can see, it make a good clean cut, but you can take a burr, an acrylic burr, and smooth that off. But the idea with these were we were trying to find something you could make in a nursing home or off campus and do something to be able to provide a fluoride tray or sensitivity tray or some other kind of tray. And again, they don't look nearly as nice as the custom fitted trays, but they work very well. And again, you got to accept it's going to go onto that gingiva. So the indications for these things would be somebody that just needed minimum lightening, like high school kids and college kids and things like that, and something you can do as a benefit to your patients for less of a fee. Works really good with that transitional dentition. So I bleached a lot of people from 10 to 14 years old because they had nice, pretty primary teeth, and now that the permanent teeth are coming in, they're very discolored, got fluorosis, different things like that. So it works good in the mixed dentition stage, or teenagers who have passive eruption. Their teeth haven't totally erupted yet, and any impressions now are going to change over time. Also, if you're doing any kind of bonding during bleaching, or you're going to add to close the diastema after you get done bleaching, this gives you a way to make a tray either as a touch-up or as a re-bleach, especially good for gaggers, because as long as they can close on their back teeth and breathe through the nose, they won't have any problem with gagging on these, and you don't have to have any lab support, and it gives you an immediate start, even if you're going to make a regular tray, and a chance for somebody to see whether they're going to have sensitivity or not. And oftentimes I'll use this as a regular bleaching tray if I can make a good one on that first idea. So here's a 16-year-old where we bleached her teeth first. You can see the left is the pre-op, the top right is the post-bleach. And then I came back and closed that diastema with some composite bonding after waiting 2 weeks for the oxygen to get out of the tooth. Now if she wanted to touch back up again over time, I could make a new tray with that same technique and not have to take any impressions of what we got there. Same thing with this lady. When we got done replacing the composites and closing the diastema and adjusting the bite, she wanted to have a touch-up tray because she was moving out of town, so we just made one of those that she could take with her. And then I also use this sometimes for caries control because we found out with carbamide peroxide, it takes the plaque off the teeth, it elevates the pH above which you can get tooth decay, and it kills some of the bacteria that cause it. So basically it's anti-cariogenic when you're bleaching your teeth. You're going to stop any caries processes going on. And then some more patients that just bleaching their teeth and they had peg laterals, and we're going to take the bonding off and then turn around and add composite. So the tray that we made initially is not going to fit after we redo the composite. So it gives us a way to do touch-ups and things. But this is the number one indication for these is this mixed dentition in teenagers. And when if you make an impression now in 2 or 3 months, it's not going to be any good because they got teeth coming in and teeth coming out. So it works really good for that. And also for some of the middle schoolers, this could be a decent sports card if they don't have to have requirements of the athletics like you do in high school. So it could make a sports card for the team. And when there's certain kind of discolorations that I don't know whether they would bleach anyway, I can do this. I can just tell the patient, let's give it a try. I'll only have to charge you half of what my bleaching fee would be. And if it works, you're ahead of the game. And if it doesn't, you haven't invested near as much money in giving it a try. So it's a good low-cost option to be able to give it a try. It's also good for delivering sensitivity treatments. And so, with bleaching, you're going to get occasional tooth sensitivity with folks, but also some people just got sensitive teeth, especially after periodontal surgery where they got some exposed root surfaces. So the nice thing about this is you can make a tray like this for somebody who has sensitive teeth just to try out and see if the potassium nitrate is going to make any difference. Because what we found is that toothpaste with potassium nitrate, the Sensodyne variety that doesn't have sodium lauryl sulfate, works really nice for bleaching sensitivity as well as just common sensitivity from eating acidic fruits or having root recession and post-periodontal surgery. The reason bleaching works is because the tooth is a semi-permeable membrane and the peroxide and urea penetrates through intact enamel, intact dentin to the pulp in 5 to 15 minutes. So we're going inside the tooth and changing the color of dentin, and that's also true with potassium nitrate. It goes all the way through intact enamel and intact dentin to the pulp in about 10 to 30 minutes. And so what you're seeing is a scanning electron microscope from Dr. Brackett of dentinal tubules and all the collagen fibers in between, and both the molecules for peroxide and potassium nitrate are small enough that they go through those little interstitial spaces. So I think the best treatment for sensitivity for bleaching and otherwise is, first of all, make sure you have a bleaching material with potassium nitrate. That can avoid it. You have the patient pre-brush with a toothpaste containing potassium nitrate. And then if they have any sensitivity, during bleaching, you have them put potassium nitrate in the tray instead of the bleaching material. And what potassium nitrate does, it's not like a tubular blocker like fluoride is. It actually goes inside and reduces the excitability of the nerves, kind of like putting topical anesthetic on your gingiva. If you put potassium nitrate in a toothpaste, it takes 2 to 4 weeks to be effective. But if you put it in a tray, anywhere from 10 to 30 minutes, it's going to numb about 95% of the patient's teeth. So it's a very effective technique. And what we use at the school, and my favorite, is Pronamel by Sensodyne. It was the first one to come out that was non-sodium lauryl sulfate, and it has 5% potassium nitrate, and it's available over the counter, so it's easy for patients to get hold and use as needed, and it has no gluten in it. So it works well with no problems on patients' gingiva. So the advantages of these direct thermoplastic trays: for the dentist, there's no lab fee. You don't need a lab. You need less chair time, so you could lower your fee possibly. It's easy for a touch-up option and good to refit after some kind of treatment, and it's very comfortable on the occlusion. For the patients, the bigger thing is they can start immediately. Once they made the decision, there's no waiting around. They're ready to go. There's no gagging for an impression. That makes for a shorter appointment, less number of appointments, which means not having to get off work and get babysitters and do things like that. And you still got all the other options if it doesn't work out well. The downside of these trays is they only come in one size. So if you have a real large arch or real small lips, limited orifice and stuff, it's hard to get the tray in, or you can't bleach all the teeth. And of course, it's not nearly as comfortable as one of the custom fitted trays made on a cast from an alginate impression. So it's got to be something the patient wants to try and is willing to accept. And again, as I said earlier, the mandibular arch is much more difficult. So here's a college student. She came home on one Friday afternoon. They usually get in about 3 o'clock, 4 o'clock. So we made a bleacher tray for the top. She went off, came back into the semester, and we made one for the bottom. But usually I'm only about 50% successful doing the lower. So I'm at the point now where I just do the maxillary arch. And if they like that and want to do the lower, it's full fee for a regular conventional lower arch. Interestingly enough, about 50% of the people who bleach the top arch choose not to bleach the bottom arch, even when it's free of charge. So you'll have a lot of patients. This would be a very attractive option because of its low cost and ease to do, and yet they're never going to be interested in bleaching the bottom arch. Here's a patient who you can see they have a large arch. He's a very large young man, and so the tray stopped at the second premolar. So that orange arrow is on the left screen is the end of where the bleaching tray was. So no longer, if he shows those first and second molars at a smile, you're going to have to go to a conventional one. So part of your initial exam is going to determine whether or not you could even try something like this, depending on how many teeth show in their smile. And again, with the mandibular arch, it's helpful if the patient holds their lips out, but they got to really be good with their tongue to form that lingual. Otherwise, very difficult to do. So again, it gives me a way to, I prefer single arch treatment because it gives the patients a chance to try it first. There's reduced sensitivity and less occlusal problems, but making a mandibular tray is a little bit difficult on that. Sometimes you'll have them where the tray doesn't quite sit in correctly, or even on a conventional tray, you're trimming it. If you trim it short of the gingiva, you don't have to make a new tray. We discovered this will go several millimeters beyond the tray, almost to the CEJ, even under the gingiva. So once you get everything covered, it's going to, by capillary action, get up into those areas. And this is my first patient I ever tried this on was my daughter. She just got done with orthodontics and hated the thought of another impression, so we decided to do this, and she became the model for a South American company that was doing this to dentists directly because they didn't have near the lab facilities that we have in the United States. So it's been very helpful. Now that led us into another area, is what about patients who have braces on? How can you control the caries and stop the white spot lesions? So it just breaks your heart when somebody is just not brushing their teeth well, and it is very difficult to clean braces. Having gone through those, I can tell you, it takes a long time every day to get those things clean. And then with the teenagers, they're drinking a lot of low pH drinks that cause caries and demineralize enamel, and so they'll get a lot of caries and a lot of white spot lesions. So what I did early on for my family was I would make impressions, and I would block out the arch wires, and I'd make the bleaching trays, and they would wear that during the orthodontics. And so after 2 years, They had no white spots and no caries around their braces and stuff. But the problem comes, it's very difficult to take an alginate impression with the arch wires on because it tears and you don't get that little area at the gingival. And if you take the arch wires off, it gets old because you have to do it about every 2 or 3 months. So the breakthrough was when I figured out how to do this directly in the mouth. In addition to using the tray, I would have the patients inject, which would be glyoxide now, directly onto the teeth, put it on the brackets for about 30 minutes, rinse it every night. I put it in a water pick, 3% hydrogen peroxide, 50% strength in that solution. Anything I could do to make a chemotherapeutic way to clean their teeth in addition to that mechanical way. So here's glyoxide that you can buy at any department store. And it's a 10% carbamide peroxide. As soon as you squirt it on there and it comes in contact with plaque, you can see the kind of cleaning area that you get around those braces. That's very difficult to get a toothbrush or a little pick of any kind in there to get those clean, especially for teenagers to take the time. There's even some patents that one lady has on using carbamide peroxide for dry mouth, but I can't say I've done much with that, but mostly just using it for caries control has worked well. So like I said, the breakthrough came through was when I figured out that I could make these thermoplastic trays directly over the orthodontic brackets without changing anything. And so that made it a whole lot easier to do. And so I have to use a little different tray. This is a thermoplastic, is a 1.5 millimeter thickness. And the reason I'm using that one is because it's bigger than that ultra thin tray. So it works the same concept, but it's just a lot bigger. And I'm going to have them use that for caries control during their orthodontic treatment. And you can see if you compare the thin tray on the left side with the thick tray on the right, you can see how much thicker that tray is, but it's also a longer tray, so it covers more of the teeth. So one of them's 1 millimeter thick, the other's 1.5 millimeters thick. Use your same ways to heat the water that you did with the other ones, Keurig or the microwave cup. You practice while the water's being heated, because these you can't come exactly in the long axis of the teeth because you'll hang up with the brackets. So you kind of have to come in from the facial just a little bit to get over the edge of those brackets. So
I'm going to slip this in and put it over your braces, and I'm going to press, and then you want to close on the back teeth and then suck the water out like a pacifier. As much force as you can. Okay? All right, so that's going to be.
So you have to go through the practice, and this one you have to be even quicker than the other two because it's really got to bend a lot to get around those braces, and you've got to put a lot of force just like you did the dual white one. So this is kind of the third level of thermoplastic tray. Start at the midline, pressing as hard as you can, being conscious about trying to wrap it over those brackets and get it to seal up against the gingiva. So I'm fixing to put this one in. And you see how quick you have to get going and pressing, starting at the midline, working your way, getting it over those braces. Just like we did with the blue tray. You got the same idea, but it's a clear tray.
Back teeth, close your lips, run it. Press up like you're kissing it. Is it still warm? Okay, open it again now.
Again, it's just back and forth between pressing from the midline to the back, inside and out.
Okay, bite in the back teeth, close your lips, run it, poke up.
And he has a very good embouchure, so I'm trying to get him
Still
tight.
warm now? Just about gone.
So we're trying to find out if it has any heat left.
Yeah, when you form your lips muscles like that, that tightens it up around there. That's great. All right, now let's get it.
Oh, so then we have a custom tray made directly in the mouth, just in that length of time. And finding how to take it off and unpin it, the better you can adapt it, the better it is to get it out. It doesn't look very pretty, but it holds the material in place. And then just like the others, you can use crown and bridge scissors to cut it if you need to. Most of the time, I just leave it smooth.
All right, now just relax your cheeks for me.
Taking it off is much like getting off loafers. You got to find that little right spot where to do it, and then all I usually do is just cut the handle off, and then make sure that they figured out how to get it in place. So a pair of crown and bridge scissors. It's kind of hard to identify where the midline is because the teeth don't look like teeth with all that big bulbous brackets kind of posting out there. But once you find it, it just kind of snaps in place.
Now close on your back teeth. Wiggle your lips side to side. That feels smooth. All right, let me take it out.
and you just kind of have to find that purchase point of where it comes out at. And then you make sure
Good, Mark. Stop it.
the patient can get it in and out. And so you let them give it a try. And again, they got the same thing. What you can feel it. If you make one of these on yourself, any one of these you can make at home and see what you think about it.
Put it back in.
But once they get the hang of where it's got to go and what it feels like to go in place, they'll find it just much like slipping on your shoes. So he's got that one in a good place. Yeah. And again, they don't look very pretty, but they cover that. They seal up against the tissue. And again, you got to be using a 10% carbamide peroxide. I actually made a mandibular tray on him, and he was able to control that pretty well. I just had the operatory light on. So if you film things with an iPhone, make sure you turn your operatory light off because that messes up the light control in there. But his actually turned out pretty good on that. Then I'm going to have them inject the material right where that line of brackets is. And you can put it on the teeth first, but like this when they're first getting started, like we did with the glyoxide. But once I've got them relatively clean, I'm going to just put it inside the tray. And it's going to take about a half of a syringe. So it's going to take a little bit more because you got all that you're trying to get clean and doing it. You make sure the patient understands how the syringes work. Make sure the top's on good, that there's a little twist off top that they can use and put it in there. And then make sure they know which side of the tray to put it on because not everybody's even aware of where the teeth are. And certainly you can't recognize teeth in this. So you make sure you show them where it's going to go and what that material looks like when it comes out. So it's like a long string of Vaseline that they're going to put in there. And then they're going to put it in their mouth. And so you can see once it goes in the mouth, all that, it comes in contact with the plaque around those brackets, it just starts bubbling and fizzing. So if you took it out, you can see that carbamide peroxide has got in places you'd never be able to get a toothbrush in there. So it just gets all through those wires and cross hatches and stuff and does a great job of cleaning. And what we found out is that there's no impact on the bond strength to the brackets, but more importantly, because of the peroxide going all the way through the enamel and the dent to the pulp, it bleaches under the brackets, so there are no yellow spots that you're going to have. So here's a patient who's been doing this for 2 years. They've been having 10% carbamide peroxide over their braces every night. At the D-band appointment, there are no white spots, there are no yellow spots. Matter of fact, if you find anything, it's going to be the composite from the bonding that was there before. And some of you have been in practice a while know you'll sometimes find composite 10 years after they got done with braces because it goes about 25 microns into the enamel. So it's hard to see if the composite's the same color. But you can look and see how clean those brackets and arch wires are there and then how nice the tooth is looking. And because this is okay on going on the gingiva and any kind of tray without reservoirs is going to work, that means you can use the Invisalign system for both bleaching with 10% carbamide peroxide. And if anybody's having any sensitivity, you can put potassium nitrate, that pro-enamel toothpaste, or a commercial version of potassium nitrate in the tray. And here's a patient that we just removed the buttons on the lower arch, and you can see they've whitened their lower arch. You can see from the mandibular teeth on the left side, and that premolar has a button on the top slide, and when you take it off, there's nothing underneath like a yellow spot. So it does a great job of getting underneath those in good shape. And they just take it out in the morning and rinse it under cool water. The only side effect of cleaning their teeth is that the teeth may get white. But for teenagers, that's a motivation of, part of why you're wearing braces is to look good. So the thought that you might be able to bleach while you're wearing braces is important. For the parent, the extra cost is going to be to avoid them having to do all these expensive restorations where their enamel doesn't get clean and they get all those white spots in area. It's good for adults for taking off coffee stains or chlorhexidine stains if they're having some concurrent treatment. Got the same disadvantage as the others. It only comes in one size, so it's not going to cover the molars, but most of the problems, the areas people have are those anterior teeth because they got better salivary flow back in the posterior. So it still works good. It just doesn't cover as many teeth as what you had. Additionally, it provides a great stable MI resting place when the teeth are in transition through orthodontics. And if they're playing sports or doing anything where they might get bumped in the mouth, it gives you some protection from the brackets, kind of like putting wax on them, but it's just a whole lot more comfortable and smooth. Generally, these have to be remade about every 2 to 3 months, depending on how much tooth movement. So it doesn't impede the orthodontics, and of course, you can't do it if they got cross elastics. But otherwise, any one day that they get their teeth cleaner is just one less day of a chance to get decay. Now, that's the different things that we can do in the mouth. Now let's take a look at some of the options that we may have for alginate impressions for a conventional tray, whether it's going to be for gaggers or some of the different areas, people that have some problem with impressions. Maybe there's some ways we can make it a little bit easier for them. Now, if you're taking an alginate impression, teeth got to be wet. You know, if they have a dry mouth, the alginate will stick to the teeth. So you have to use PIP spray in the mouth as a gentle lubricant to be able to lubricate the teeth. And then you make sure you wipe the alginate on the occlusal surfaces and on the facial, and then seat the tray completely while lifting the lip. Then after you take it off, you rinse it, disinfect it, wrap it up, then rinse it again, and pour it in 45 minutes ideally. And if not, put it in some kind of Ziploc bag or humidor so that the alginate won't store it. Alginate works really well because it's easy to get the cast from undercuts. Now, sometimes you need an alginate impression for diagnostic purposes to mount on an articulator, as well as something to do with bleaching. So what we found out is that rather than trying to duplicate one cast and use it for a bleaching tray, that if you double pour an alginate impression, if it doesn't tear, and you keep the first pour wet by wrapped in a wet paper towel, putting it in a humidor for about 45 minutes, you can pour the other side and get the same quality you would if you took two impressions, especially a whole lot better if you tried to duplicate one by soaking it in water and taking an alginate impression. So as long as you don't get tears in your alginate after separating that first cast, you can get two good casts and use one of them for bleaching, use the other one for mounting on the articulator. That's important to understand because one of the neat impressions for a gagger is to use an alpha triple tray. These are the same people that make the triple tray for Crown or Bridge. That's Premier. And what they also do make is a full arch tray. Comes in the same three sizes of large, medium, and small, just like their regular stock trays do. But the idea is you can take an impression of both arches at the same time by having the patient close into MI. And the reason that's important for gaggers is because you can't throw up when your mouth is closed. So as long as they're able to breathe through their nose okay, they'll be able to fight that urge to feel like they're going to throw up because they got their teeth together and they don't feel anything going down their throat. So what you do is you mix one 3-pack, 3-scoop of alginate, just like you do a large maxillary impression, and then load both sides of the tray, seat it on the mandibular arch first, and then lift the lips and have the patient close on their back teeth and put the lips over and kind of form it around there. When the alginate sets up, you're going to have an impression of the lower arch and of the maxillary arch that's going to go onto the gingiva and actually give you something good for a cast. So then you pour the maxillary side first, usually is what I do, and then wrap it up with a wet paper towel so that the alginate won't distort. And then after 45 minutes, or even as soon as the stone gets where it's lost its gloss, you can almost flip it over, pour up the other side, and then when they're both set up, you've got two casts that you can trim. It makes a very nice bleaching tray. So it works very good. The patient makes tiny little holes, but it doesn't mess up enough to have the tray because those are only occlusal contacts, and so the stone will go through there and be in good shape. So the alpha tray works really good for gaggers. It sometimes conditions the gaggers for future traditional alginate impressions because they now learn to bleach through their nose while something's in their mouth. And again, just works very nice. And then the thermoplastic trays avoids the alginate impression completely. Another option for a gagger is just use a mandibular impression tray to make a maxillary impression. That avoids getting things on their palate and that feel of something going down their throat because it's all over in the buccal vestibules on both sides. There's another option you could think about that's using a putty wash with a hard tray to carry it to the mouth. And the reason this is sometimes helpful is because putty doesn't feel like it's running down your throat like alginate does, but it's got a long set time. So you take your putty, your two base areas, and you use a wash material on the inside. We do this sometimes when we don't have time to pour up impressions anytime soon because you can take the impression one day, pour it up all at the end of the week. And so we're going to use a regular stock tray like you would use for Crown or Bridge and put regular adhesive on it. Take a scoop each of the base and the catalyst, mix them up and make a long hot dog. Not fill the whole tray, but just make a hot dog that's going to seat in a horseshoe fashion into that tray. And then make a little trough there that you can use your light injection body and inject into that trough. Then with it, this is a PBS putty, so you're going to come to the mouth, dry the teeth off real good, lift up the lip, and then seat the tray with them going right into that little horseshoe shape and seat it all the way till it stops. And then it just feels like they're biting into thick putty but it doesn't have that gaggy kind of feeling. It doesn't run at all. So you've got a very stable thing. The only challenge is it takes about maybe as long as 6 minutes to set up, which is a lot longer than an alginate. But if they're breathing okay through their mouth or through their nose, it works out good. And when you get done, you get an excellent impression of all the teeth and the adjacent areas. Some teeth will touch through because you press so hard, but you don't have anything going down their throat, and it's going to be nice and stable for you. So if they have periodontally involved teeth, the fact that you touch the tray may move on a little bit, but again, not so much that it's going to mess up your bleaching tray. The only challenge with these is they have to degas. So you got to wait at least an hour before you pour them up. That's why this works very nice for our bleaching research. If we're taking multiple patients all in one day and taking lots of impressions and don't have time to pour them up, we just take a bunch of PVS impressions and let them set aside, and then the next day somebody comes in and pours them up. So with the PVS impression though, teeth need to be dry. The light body is going to capture the details, and then you're going to disinfect it and wait at least 1 hour before you pour. But this thing will be stable for months, so you can get double pours out of it. The challenge is if you have really thin teeth, it's difficult to remove the cast without fracturing the stone. So again, these are all non-scallop, no reservoirs tray. And our original article back in 1989 showed a non-scallop, no reservoir tray, and that's still the best standard for giving you a good seal. It's easy to make, it's comfortable to the patient, but again, designed to be for 10% carbamide peroxide. The higher the concentration, the more likely you're going to have to do scalloping, and if you do scalloping, you're going to have to use reservoirs to keep the tray from flaring out from the thickness of the material. Now, some of the additional usage of these trays and stuff is that we use bleaching materials for caries control. And what is because in our research we found out that during bleaching the teeth are squeaky clean because you take off all the plaque, and that the pH with carbamide peroxide is elevated by urea to above 8 within 5 minutes after putting it in the mouth, and the 10% carbamide peroxide kills some of the bacteria, and it improves the gingival index scores. So it's a very healthy sort of thing. So if I'm got patients who are having a lot of root caries, and again they have root caries because the pH for enamel to get caries is 5.5. The pH for dentin to get caries is 6.8. So once somebody gets a little bit of a dry mouth from medication or aging or whatever, they'll get a lot of root caries, but they won't get enamel caries because their pH is below 6.8 and above 5.5. So if fluoride's not working, then the next thing I want to go to is making a bleaching tray and use the carbamide peroxide to elevate the pH because of the urea. Or if they're on chlorhexidine and they won't do the chlorhexidine because it builds up stains, you can alternate one night with chlorhexidine, one night with a bleaching tray. And if you've got folks that are just difficult to clean their teeth because of physically challenged things like arthritis and stuff, or mentally handicapped things, it works good. And then we talked about using it to stop the white spot lesions from ortho and reduce aphthous ulcers and bad mouth. So it's got a lot of little other things you could use. And the secret is getting it into a tray so that you can get it into their mouth and it can do what it needs to do, because it's a slow-acting, long-lasting sort of material. Now, if I'm using carbamide peroxide for caries control, I use two different codes. I use the fluoride gel carrier, D5986, and I use the other drugs or medicaments, D9630, for my carbamide peroxide. And then you can get the carbamide peroxide from the bleaching companies. A lot of those you can buy it over the counter as glyoxide or from CVS, or you can get a pharmacist to compound it. But again, you got to use something that will work in a non-scallop, no reservoir tray, because that's the way all these trays are made. I'm using this for caries control in cancer patients, keeping them from getting caries because they've had head and neck radiation and they don't have any salivary glands. The one thing I found about both cancer patients and some females is you need to avoid the mint flavor. That tends to set their gingiva kind of on fire and it gets them irritated. But if I switch to a regular melon, all those problems go away. So I use a very bland material when I'm using the bleaching materials for caries control. And so the protocol is I'll make two trays, one for the maxillary and mandibular. They can wear one tray each night, alternating. It only takes about 4 to 6 drops. We don't have any double-blind clinical trials, but this is my recommendation when you reach that point where you're losing the battle with everything else you're doing. It works great for elderly folks, radiation patients, dry mouth patients from medication, handicap, and also these full mouth reconstructions. You just did all these crowns on somebody because they had a lot of decayed in teeth and broken down teeth. Well, the places those are going to fail are right at the gingival margins. So if they're not keeping good care of their teeth, or if they got dry mouth radiation issues, then making a bleaching tray and they just wear it over their prostheses. It's not going to change the color of the porcelain, but it'll keep them from get caries around the margins. And then you got to look at all the other things they could be doing: xylitol, gum, or mints, making sure they're using sugarless mints, making sure they're brushing right before they go to bed, because that's when their salivary flow is the lowest, and then making sure they're using fluoride water, because most bottled water doesn't have fluoride unless you buy it in the nursery section. All right, so there's some other options where you can combine all this stuff together and think of. One of them is when you're trying to make a bleaching tray for somebody who's in a hospital, and they can't get out and they got active decay, and you want to stop it while they're trying to recover health-wise. So what you can do is you can't do the boiling form because of all the issues of infection control and stuff, but you could use a combination of the putty by taking the little putty material and putting 1 scoop in a Ziploc bag of each kind. You don't have to have any water, you don't have to have any suction, and you can make the little putty impression and then take it back, drop it back in that Ziploc bag, and take it back to the office, disinfect it, and then generate everything in the lab. So I would make the little putty, again, just like before, but instead of using a rigid tray, you can also just use that little ultra thin tray and use that as a carrier, because once the putty sets up, you're going to have a nice tray. Then you can take the putty out. You take the tray out first, then kind of peel the putty off the teeth and get it out, and then drop them both into the little bag. Then when you get back to the office, you can disinfect it and then put them back together and then pour it back up, and you'll create a cast that you can then go through all the process of trimming it so you have central straight up and down, no vestibule and a hole in the center. Black out anything that's questionable because you're not going to have any chance to adjust it, and then make a conventional vacuum form cast and trim it so that it goes about 1 millimeter or 2 onto the ginger and goes around the insides of the papilla. Another option would be, instead of using that soft tray, is use a hard tray, but again, you're worried about it locking in the mouth with this putty, and so but you want to force it around the teeth really well, so you put masking tape over all your retentive features, then use the tray as a carrier to seat the putty all the way into the mouth, and then works really good on mandibular impressions, as you can see here. And then you can either take it all off together, or you can take the green tray off first and then kind of peel the putty out of the mouth. Do the same thing with the others. Take it back to the office, reassemble them, pour them up, take them back apart, and then you can either peel that putty off the teeth so you don't break them, or actually cut it off. Especially if you know you have little thin lower anterior teeth and you're worried about them breaking, and you don't have to go back into that hospital situation. So it kind of gives you a different way to do it. And then you trim it like before, block out anything. Again, you don't usually block out this much, but when you're going back in with only 1 shot for the tray to fit, you'd rather have it a little loose and a little tight around those teeth, especially if you got a lot of undercuts. Make your vacuum form tray just as conventional. Excuse me. So that gives us some different options of those tray options. And again, I think the 10% carbamide peroxide in a soft tray is the most cost-effective and safety feature. And a lot of these articles, you can find them on my website, vanhaywood.com, with pictures before and after bleaching, and articles from some of the journals and some of the ones about these kind of trays, and interviews, and how the Lord led me to write that first article and getting that started, and some of the links to the continuing education. The last thing I want us to talk about, because it kind of fits into this whole same concept of how can we do some shortcuts, is the ways that we're making splints, and the ways you might want to make a record for a splint. The purpose of this splint is going to be protect the teeth from wear and forces, and give a more favorable occlusal scheme than you could be obtained with natural teeth or crowns, and protect the muscles from overuse and discomfort, reduce the resting activity of the muscles, and protect the temporomandibular joint from discomfort. So there's lots of different types of splints. And again, the ADA code has changed again. Now the hard splint is D9944, and the thermoplastic soft splint is a D9945. So those are new codes. Lots of different ways to make splints, whether they're in CR and MI, whether they have an anterior ramp or flat, whether it's on the maxillary or mandibular or partial coverage. I'm just going to focus on the basic one I make, which is a splint in CR with an anterior ramp made on the maxillary arch. And so of the 3 diseases we deal with, we got periodontal disease, we got caries, and we got occlusal disease. And so for bruxism, that just destroys teeth. So we need a predictable way that generates a splint that's easy to fabricate, easy to seat clinically, got good retention, and doesn't require a whole lot of chairside adjustments. So one of the best ways I've found, and what we do at the dental school, is rather than mount the cast on an articulator and then open it up for the thickness, we make the interocclusal record at the vertical dimension of occlusion for the splint, so that there's no arc of closure issues and arc of opening issues, and you don't have a whole lot of chairside adjustment. So we use a leaf gauge to make the amount of clearance that we need for the splint in the mouth, and then take the IOR at that so that the casts are mounted at the vertical dimension that we're going to use. And so we usually add some to the middle, and I'll show you how we're going to do this. So we're going to take a leaf gauge, we're going to deprogram them, that's going to put them in CR, and then we add enough leaves on the gauge to get that 1.5 millimeters at the closest speaking point. Then we're going to turn around and use that same leaf gauge at that open vertical and inject the Blue Moose or interocclusal record 30-second fast set material in there, and then take out the leaf gauge and inject a little bit more in there so that we complete the IOR. So here's how you use a leaf gauge. You want to make sure that the patient slides forward and back, otherwise they tend to bite on the front teeth and you won't get the patient in CR. So this is one of Leanne Brady's tricks that I dearly love. And so we're going to then, once the patient's got used to doing it, we don't let them close again. And this material that you're seeing here is a little bit brittle, so I apologize for that. But you'll get the idea that you stack it up on the teeth all the way around, and you just inject them directly in the mouth. They've already been deprogrammed and they've practiced. Now we're going to put that same leaf gauge right back in the mouth. They're going to slide forward on the front teeth and then slide back on the back teeth. And then in about 30 seconds, you're going to have that interocclusal record ready to go. Once it's set, then we're going to take the leaf gauge out, hold everything in place.
Look in the posterior for any problems. Looks good. Okay, so I'll add.
At any place that we didn't get good teeth in indentations, we're going to add more PVS. Again, they'll close right back down to that same EMI. And the IOR stuff will bond to itself, and so you'll have a nice little horseshoe. So there we are, opening up. There we are, leaf gauge biting in there. Then you notice we got to peel that out and squirt any of those places where you see it's too thin so that the lab has a good solid IOR to be able to mount to. Otherwise, sometimes it'll break right there, especially if you're trying to seat it. So we're going to inject right back in that little area. And then when the lab mounts it, you just got to make sure they set the pin to retain that same vertical dimension of occlusion. Then your cast is going to be, when it's mounted, it's going to have that same space that they would have had otherwise had they opened it up. But this way it's going to be exactly what the patient does, not what the articulator hopefully does. They just got to make sure they set the pin. And because you're making it at the vertical dimension of occlusion, you don't have to worry about whether it's a semi-adjustable articulator or just a hinge articulator. So long as it's got a way to set the vertical dimension at that setting, then you're going to be in good shape. So that's the general idea for making that splint. Another way you can make a splint is just making it directly in the mouth using either PMMA or composite on your occlusal surface. So you just take one maxillary impression and then do a vacuum form splint material like you would make in Essex or something like that. Trim that off your cast so you've got that where it seats in the mouth, and make sure it's got retention and that you can get it in and out. And so this is that Proform .080 inch splint material for the vacuum former, and we got that ready to go. And then what we've published an article on is using LC blockout, which is laboratory grade material used for making reservoirs on bleaching trays and blocking out undercuts and things like that. But if you put PMMA liquid on the base of that splint former, then you can bond composite to it. You could use acrylic, but patients tend to object with that smell and the taste of it, and there's a greater potential for locking it on with the opposing teeth because it's so runny when you put it on. So we just activate that splint with the material. We've got a leaf gauge in the front to deprogram them, put them back in CR. You put the composite on the posterior teeth and then have them do the little leaf gauge trick and bite into that composite and then light cure it, take it out and light cure it again. And now it's hard, put it right back in the mouth, squirt composite around that anterior segment, and they bite into it. And then you just got little indentations, and you put a pencil mark at the bottom. You trim the posterior teeth flat, and you trim the anterior teeth with a slight ramp that's going to disocclude the posterior teeth. Works out really nice. It looks kind of funny because you got this blue on there, and of course you could use regular composite, but that's kind of expensive. But you trim it flat on the posterior, ramped on the anterior. Brasseler E-cutter works real well to smooth that out. So we've eliminated all the depressions for a nice smooth flat surface with flat posterior and ramped anterior teeth, and you can polish it like a denture. And so that's just a nice way to make an immediate splint without having to go out to the lab. You just got that one cast to pour up in the vacuum form. And so again, saves you some lab time, and it may help somebody get through something without going through all the Facebook and different things you might need to do, or going with the additional lab costs that you might have to do. And again, you have to use that PMMA liquid on that hard splint material. And then we're going to use the LC blockout just because it's a lot less expensive and it's easy to trim and it wears very nicely. We also use that LC blockout sometimes to make to do a diagnostic wax up, so that you can make a bleaching tray and in turn put a tooth in there made out of composite, like you see here, maybe when you're doing an implant and you don't want anything resting on it. So this young man had an internal resorption on an anterior tooth, needed to be extracted and have an implant. So we made an Essex bleaching tray, and as you can see, there's the bleaching tray with the composite tooth, and it doesn't rest on the implant, so that you can get healing and you can trim it and you can add to it as he moves along. He even had an article that Phil Baker, a prosthodontist, wrote where a fellow had his front teeth knocked out, and so they had him wired together for a while and using chlorhexidine, and so his teeth are all stained. He wants to bleach them, so they just put denture teeth into the bleaching trays. And again, use the triad sort of resin, the triad VLC bonding agent is what will allow the acrylic to bond to a bleaching tray, because all these trays are a little bit different material, and that gives them some aesthetic looks, but it also gives them something where you can trim off the gingiva underneath where they're going to add bone in there, and then they're going to put the implants and stuff in there. So it gives you a little bit more flexibility with giving you the same kind of partial look. Here's another one where we're replacing a couple of teeth. We've got to wait for the implant to heal, and nobody really notices you have a bleaching tray in. Plus, you can be bleaching your teeth, so it just gives you a nice option. So for these anterior teeth, oftentimes you got to have a splint, especially for bruxers. And now that with Jeff Rouse's article on things, people are seeing a lot of correlation between obstructive sleep apnea and the signs of bruxism from children all the way up to adults. So we're going to be looking at ways to deal with that. You can make a splint on a simple hinge or no articulator at all if you understand the principles of how you're going to make the splint. And the important thing is taking the interocclusal record at the vertical dimension of occlusion plan for the splint, because that minimizes the arc of closure errors in all cases, and it constructs the splint in CR, which is best for jointed muscles. And then sometimes you can use that little blue-white one, that thermoplastic interim splint, to determine if the patient can wear a process splint or if they're still bruxing, or if you have some acute TMD problems and you want to give them something to change their pattern of occlusion. It's not as good as a lucid jig or MTI or something like that, but it is a quick way to try something in that. So now we've covered a number of different novel tray options and techniques, different kind of bleaching trays and sensitivity trays and caries control trays that you can make directly in the mouth, or techniques that you can use for taking alginate impressions of gaggers and putty wash impressions and combination things, as well as some ways that you can make some simple splints, either from an impression only, or just using the trays as a way to figure out whether somebody's actually grinding their teeth or not. So there are more important things in my life than bleaching teeth and making dentistry stuff, and that's a lot of the family. I've got 3 children and 4 grandchildren, and we're having a ball as we enter into this grandparent age. So I thank you for supporting the Georgia Dental Association and being part of this venture, and for paying attention to this lecture, and I hope it'll be a blessing to you in your practice, and that we'll see you around at the dental school sometime.